addition, all of these videos, all these lectures are being recorded. So following the event, sometime later this afternoon or later this week, all of the videos, all of the lectures from our speakers this morning will also be published on the Critical Care Symposium login. So without further ado, let's get started. We are focusing this Critical Care Symposium on overall the topic and theme of current controversies in resuscitation and critical care. One of the most basic things, it would seem, that we use to resuscitate critically ill patients, sick patients, is the administration of IV fluids. And there's lots to talk about with respect to IV fluids. And to get us started with our Critical Care Symposium this morning is a good friend, Dr. Rory Spiegel. Rory, many of you have worked with in the past. Rory did his critical care training here at the University of Maryland and then went down not too far to Washington, D.C., where he is currently an assistant professor in the Department of Emergency Medicine at Georgetown, and then splits his time in the ED and ICU at Washington Hospital Center. He's also the director of their critical care education within emergency medicine. So without further ado, I know Rory loves to wax philosophically on IV fluids. So please welcome Dr. Spiegel for his discussion on IV fluid resuscitation in the critically ill.
Thanks, guys. Can you hear me? Okay. That was kind. Philosophically is generous. I think it's on. I got a green light. I don't know. Mike can tell me if I'm actually on. So we're going to talk about fluids. The slides will come up in a sec. This is somewhat of a conceptual talk. I often, when I talk about fluids, either kind of review the literature or talk about VEXUS, which is just kind of Doppler ultrasonography of venous return and venous congestion quantification. But I find either one of those topics kind of leave a hole in the exact management of fluids, and so this is more of a conceptual talk about like how I think about IV fluids and how you think about administering them, and what tools you can use to decide when to give fluids or not. And so the harms of fluids are fairly well documented in the literature. What we do know is patients who get more fluids have worse outcomes, and these outcomes are in the forms of renal failure, ARDS, and even death, right? But a lot of this data is confounded by the fact that sicker patients get more fluids, so it's hard to know if it's just the sickness of the patient or the actual fluids that are causing harms. But we do have RCT data that is fairly suggestive that IV fluids, if used incorrectly, can cause a lot of harm. One of the most convincing is the FEAST trial. This was a trial of children in sub-Saharan Africa with sepsis that were essentially randomized to get an IV fluid bolus or no IV fluid bolus. Both sides got antibiotics and source control, but you essentially randomized the fluid bolus or not. And one of the really interesting things they did with this trial is they actually asked the clinicians in the moment which patients did better. And they were basically just using clinical monitoring. So did the children pink up? Were they active? Were they eating and drinking again? And almost to a T, all the patients who got the IV fluid bolus pinked up faster, shock resolved quicker. The problem was they just died more frequently. Right? There was a 2% increase in mortality in patients who got the fluid bolus. And again, these harms came in the form of respiratory distress. There was a lot of thought that that trial had no external validity to what we do here. Children in sub-Saharan Africa, inability to intubate and ventilate the patients. But they did again. They did in adults. Again, sub-Saharan Africa, adult patients presenting in septic shock. And they are randomized into like an early goal-directed like group who got fluid resuscitation, IV antibiotics, versus IV antibiotic source control, and that's it. And again, the patients who got the fluids cleared their lactates faster, their shock resolved quicker, they just died more frequently, right? So this is real, this idea that if fluids are used incorrectly, they can certainly cause harm. And I just want to be specific in kind of what this harm is. I think people often find this surprising, but like someone comes into your ED with abdominal sepsis, and they go down the line to develop ARDS. How'd that happen? Right? You take a sick patient with leaky capillaries, you lie them flat, you sedate them, and you give them a bunch of fluids, And their lungs, day after day, gets wetter and wetter and wetter, and at some point you start to notice when they develop ARDS, right? ARDS, abdominal compartment syndrome, these are all diseases of hyperinflammatory states combined with our resuscitative efforts, which lead to problems, right? But it's not, we can't just say don't give fluids at all, right? If you actually look at other data, when we just simply restrict fluids from patient populations, you see there's actually increase in renal injury, increase in morbidity. And so we need tools to actually quantify when to give fluids and how to give fluid, right? And I think a lot of problem with the literature and the quest of finding tools to decide when to give fluids is we want something like this. We want a magic 8-ball that basically tells us yes, no to give fluids, independent of who the patient is, independent of what the disease is. I just want a dichotomous answer, right? But often the tools that we're using look more like this. And I think probably the most intellectual lazy of them is the lactate, right? I think most of us at this point are familiar with the lactobolo reflex. Some of you will notice some of the authors on this are former residents here. But this is the idea that you see an elevated lactate and you respond by giving the patient fluid, right? And if the lactate doesn't clear, you give them more fluid. And we are all susceptible to this, right? And lactate started as this idea that the reason a patient has an elevated lactate is that they have end organ malperfusion, right? So they're basically in anaerobic metabolism, right? And the way to fix that is give them a fluid bolus which augments cardiac output, thus delivering more oxygen to the tissues, thus reducing your lactate, right? And in concept, that at least makes sense, but when you start thinking about it, there's a bunch of flaws. The first one is there's many diseases that cause end organ malperfusion that aren't due to a decrease in blood volume, right? Take cardiogenic shock, pulmonary embolism, GI bleeding. So there's tons of stuff where the lactate's there, but giving them fluid is not necessarily going to help. But let's just pretend for a second we've got a septic patient. And the theory here is, again, the lactate in sepsis is due to end organ malperfusion. It turns out mostly it's not. It turns out most lactate, what you see in sepsis, is actually due to the sympathetic response of the host to the stressor, right? If you give a kid albuterol, what happens to their lactate? It goes up, right? If you give someone epinephrine, what happens to their lactate? It goes up, right? So the own host sympathetic response to the infection increases their catecholamines, which shift their pyruvate to lactate ratio, which essentially increases your lactate, right? But the point of all that is it has nothing to do with end organ malperfusion and has nothing to do with the idea that if your lactate's up, I can augment that end organ malperfusion by giving them fluid, right? And this has actually been shown in trials like adrometer shock that using lactate to titrate your resuscitation leads to worse outcomes. So probably the concept that is thought of as at least more like sound is fluid responsiveness. And fluid responsiveness is this idea that if you give someone a fluid bolus, you're going to increase their cardiac output by about 10 to 15%, right? So at least conceptually, you're doing what you want that fluid to do, right? I want to give someone fluid because I want to augment cardiac output because I want to help deliver oxygen to the tissues, right? And so the straight leg ray was born. Has anyone ever had to do this? It's kind of a pain, right? Like you have to keep walking in the room. You need people to hold the legs up. I need some form of cardiac output monitoring, right? Because I can't just use blood pressure. So someone else has the ultrasound probe on, looking at the VTI. It's just a pain. The good news is it doesn't really work and you don't have to do it, right? And I'll tell you, we've had data for years that this concept doesn't work. If you go back to the 90s and look at the SWAN data, where they actually had a SWAN in patients and they resuscitated them to actually augmenting their cardiac output, what happened? It didn't improve benefits at all. And for some reason, we blamed it on the SWAN and not the actual resuscitative strategy, right? And so why doesn't this concept work? So I think it's a couple reasons. The first is if you drive someone to the flat portion of their Starling curve, you've essentially iatrogenic fluid overloaded them, right? We all exist on the steep portion of the curve. And so giving them fluid until they're no longer fluid responsive just leads to fluid overload. The second thing is, do you guys know how long the increase in cardiac output lasts when you give someone a fluid bolus? Somewhere between 30 minutes to 2 hours, depending on the hyperinflammatory state of the patient.
So us, it's about 2 hours, but you get a septic patient or patient with pancreatitis, it lasts far less. And what's happening to all that fluid? It's just leaking out, right? It's just going into the lungs, going into the abdomen. These are the exact side effects that we're having, right? And so there's a movement to move away from this idea of fluid responsiveness or a surrogate outcome. You're basically asking, will this fluid bolus increase cardiac output, to something more holistic, right? And it's what's known as fluid tolerance. What fluid tolerance asks is, what is the likelihood that my patient's going to benefit from fluid versus what is the likelihood that they're going to be harmed from fluid, right? That's a much more like subtle and difficult question to ask. It's not just a yes, no on a dichotomous test, right? You have to understand a lot about the patient, about the disease, about the point they are in their resuscitation. And so it's much more complex. So people don't like it. But it turns out critical care is complex, right? And so this is the kind of stuff we have to understand. And this is what I want to kind of talk about, how we think about a fluid administration. So I've kind of termed this thing the Bayesian approach to fluid administration. Do you guys know who Bayes is? So Bayes essentially was a minister that came up with a way to like statistically analyze stuff. But essentially, he had a concept that you're making an observation, you have a prior probability of that observation being true. You make the observation you're making has certain strengths and weaknesses that shift that probability to a posterior probability of whatever you saw being true, right? We use this all the time diagnostically, right? This is how you do most of your diagnostics in emergency medicine. Probably the most classic thing here is PE, right? When you do a Wells score, what it's doing is calculating your prior probability and then kind of assists you on what tests can get you to a posterior probability that is useful, right? So if your Wells score is low enough, the diagnostic characteristics of a D-dimer can shift you to a point where you no longer have to do any further testing, right? But if it's too high, you would then have to go get a CAT scan, right? That's kind of the way Bayes' theory works, right? You can do the same thing with your test to see if someone is fluid tolerant or not, right? And so essentially it looks something like you've got a prior likelihood of fluid tolerance or intolerance. You've got some signs of fluid tolerance, intolerance that we're going to talk about, right? And that's going to give you a posterior likelihood of whether the patient will benefit from fluid or not. And you just do this nonstop throughout kind of seeing your patients. But this is kind of how we should thinking about when or when not to give people fluid, right? So let's look at our prior likelihood of fluid tolerance, because this can get a little complicated again, because patients aren't monoliths and disease aren't monoliths, right? We exist with patients have different comorbidities and different states, and diseases are different than each other. Sepsis is not a pulmonary embolus, is not a GI bleed, right? And so the first thing we want to look at is your patient. Like, what are the actual characteristics of your patient? Could be tolerant, intolerant to fluid, right? Because someone with CHF who gets sepsis is much different than someone who's young and healthy and gets sepsis, and their response to fluid will be much, much different. So you want to look at the patient, you want to look at what disease states you have, you want to look at those characteristics. The next is the disease itself, right? Because different diseases have much different profiles in whether they like fluid or not and how much of an injury of fluid they can take. And the third part is what point in the resuscitation you're actually at, right? A septic patient who's had 3 days in bed, hasn't eaten or drinking, looks much different than that same septic patient 24 hours later when they're 12 liters positive, right? Same patient, same disease, but you're at a different point in the resuscitation. And so your factors on whether fluid help or harm are much, much different at each one of those points. All right, so, I guess the slide's repeated. So what you can do is kind of put these factors on a graph where on your y-axis you have your disease factors, and so as you go up, you have more harm from the disease states you're in, and on your x-axis you have the patient benefit or harm depending on their state, and you can basically exist in 4 quadrants where you're more or less harmful on fluid. So your upper right corner is where you probably have the most initial harms of fluid, right? And as you shift down to your lower left, this is where the likelihood of harm in fluid is pretty small, right? And you can exist in this. But again, remember the resuscitation and the time actually has a factor. So, you know, you can almost think of this as a 3-dimensional model where time goes out, right? And so this, even if you have the same patient and the same disease, over time, the risk-benefit of fluid can change, right? And so let's just look at that z-axis versus the disease as some examples, right? So take something like sepsis, right? Sepsis is a hyperinflammatory state, so you have very leaky capillaries. Before you get source control, you are far more likely to leak fluid out into the interstitium, and fluid is far more harmful. As you get control, source control, and that hyperinflammatory state starts to go away, fluid becomes less and less harmful over time, right? Just based on the disease state, right? Something like hemorrhagic shock, right? Early, before you actually have control of the bleeding, fluid just leads to dilution of your coagulants, hypothermia, worsening your shock, worsening your bleeding, spiking your blood pressure, worsening your shock, worsening your bleeding, right? So we all know we don't want to give fluids early in septic shock. Once the surgeons take them to the OR and get source control and they come back to the ICU, the harms of fluid aren't quite as high because they're no longer bleeding, you're no longer diluting that out, right? They're not zero, but they're not quite as high, right? But then you have disease states like PE, right? PE causing shock. It's pretty high risk to give fluids at all points. There's really no point you should be like, oh yeah, this patient could, you always want to think real hard. The harms of fluids are really high in someone who has core pulmonary, right? And then other diseases like subarachnoid hemorrhage, where they're seemingly able to tolerate huge amounts of fluids. I mean, we get them in the ICU and we're running fluids into them for like a week on end, and they get so much fluid, and some of them go on to develop ARDS and so forth, but far fewer than these diseases of like massive hyperinflammatory states, right? So understanding the diseases is a super important component to understanding when you can give fluid and how much. And then finally, it's the resuscitation, right? That's the last factor. And this is a really interesting one because this is like really where the Bayesian factor comes in, right? Because the more fluid you give someone and the less it's working, the less likelihood that more fluid's going to help, right? If I'm 13 liters into someone's resuscitation and they're in shock still, the likelihood that that 14th liter is going to be the answer is pretty low, right? So it doesn't matter what your ultrasound findings show. It doesn't matter what you're seeing. If you're 15 liters in, more fluid's probably not the answer, right? And you see this in the diseases like pancreatitis. Like if you look on ultrasound in a patient with pancreatitis, they're always empty. Like severe pancreatitis, they're in horrible shock. They're always empty on ultrasound, right? Their IVCs are flat. Their heart is hyperdynamic. They're underfilled because they're just leaking it all out, right? And they will get ARDS and they will get abdominal compartment syndrome before you ever fill them up, right? And so it's really important to understand these factors as well. Okay, so that's the prior probability, right? Now we're getting to the part where we're actually doing stuff, which is signs of fluid tolerance, intolerance, right? And you all have some, right? Whether it's lactate, IVC ultrasound, the old school one is like giving fluid, listening to the lungs till you hear crackles and then stopping, right? It's like a real way of fluid intolerance. It's probably a late one, right? You probably could have stopped earlier, but it's an actually valid concept, right? So what do we use? We can use a lot of stuff. So Vexus, Vexus is venous excess on ultrasound. It's essentially a Doppler examination of the portal, hepatic, and renal veins where you can actually see venous return flow curves. And as people get congested, you'll actually start to see congestion or backflow of fluid going the wrong way, right? And essentially you can, in my mind, you can break down like the harms of fluid into two factors, either vascular congestion, so venous congestion, backing fluid up through the venous system, which leads to increase in venous pressures, which leads to poor perfusion across the organs, right? Because remember, perfusion of the organ is not just your MAP, it's MAP minus your CVP, right? And if your CVP goes up, you start to decrease perfusion across the organ. That's what venous congestion does. And so Vexus is probably one of the better ways of looking at this. The basic way, which I'm sure you're all familiar with, is IVC ultrasound, right? IVC ultrasound basically tells you Vexus light. I would tell you there's a lot more nuance to venous return and venous congestion than just an IVC ultrasound can tell you. But it's not bad. When your IVC is full, your right atrial pressures are significantly high, right? And you have a significant chance of venous congestion. And so both of them work reasonably well. Vent mechanics is a huge one, right? This could be a whole nother lecture on itself, but as people get volume overload, what happens to their lung? They get wet and heavy, and they just turn into these little balls. They just get smaller and smaller every day. And there's good data on this. If you just take normal, healthy people, sedate them, lie them flat, and give them fluid, every day they lose lung volume, right? And ARDS is the end result of that, right? That's all the way down here. But you shouldn't be surprised your patient got ARDS. It shouldn't be like all of a sudden I'm shocked they developed ARDS, because that happens slowly over time. And if you're paying attention to your vent mechanics, you'll see it. I find the easiest and most notable one is a patient's minute ventilation, right? As their lungs get smaller and smaller and smaller, their minute ventilation requirements go up because there's a VQ mismatch, meaning the amount of times they have to breathe to manage their CO2 just goes higher and higher. And if you're watching it, you'll see it. Their minute ventilations go from 7 or 8 to 9 to 10 to 12 to 15, right? That's the first sign that lungs are just turning into a wet, heavy ball, right? But as that happens, your risk of continual fluid administration gets higher and higher and higher, and you want to be aware of it. Pulmonary edema, right? That's the other one, right? So it's vascular congestion and then extravascular edema are the two real signs of harm with fluid administration, right? And in this case, you can just look at a patient, right? There's plenty of times, especially in the ICU, where 12 liters in, they're massively puffy. You can't get peripheral lines in anymore, and they're just like weeping fluid out of their skin. That's fluid intolerance in my mind, right? And then pulmonary edema. Again, you can listen to the lung with crackles, but obviously we have more technology at this point, and ultrasound is fantastic at looking for B lines and pleural effusions posteriorly. And then other stuff, ACS, abdominal compartment syndrome is a big one, end result, but simply patients with open abdomens that you're trying to go back and the surgeons are trying to close, and they can't close because there's tons of gut edema, right? Same idea. Other POCUS findings, so decreased LV function, your TAPC is decreasing. All these things are signs that the fluid is starting to be a cause of a problem. And any other of these signs, right? But you're putting this all together, right? Not one of these things works independently. These are all signs, and they all have certain strengths and weaknesses, and you have to take those into account with the patient that we are looking at in front of us, right? And in the end, that's what's going to give you your posterior likelihood of benefit or harm. So that's a lot, right? It's a fairly complex theory, but again, critical care is not simple. So how do we actually figure this out? So I think the first thing you have to think about is the patient actually in shock, because I think what a lot of times we confabulate is hypovolemia, hypovolemic shock with dehydration. And they're different things, right? And we want to treat them differently, right? Because the reason we're giving someone a fluid bolus and hypovolemic shock is because you want to rapidly restore perfusion to the organ, right? And I'm using a tool that's not that great. Remember, it only stays in the actual intravascular space for 2 hours at best, but I'm using it because I want to rapidly restore perfusion, right? But if someone's dehydrated and their perfusion's fine, I don't need to use a fluid bolus. In fact, it's the less efficient way to rehydrate people. Using the gut is way better to rehydrate people, right? So if you can use the gut and they're just dehydrated, just rehydrate them with the gut, right? So identify that you're actually in hypovolemic shock is an important factor here before you start giving fluids, right? The next thing, which is super important, is phenotype your shock. Figure out what type of shock the patient has, right? Because fluid boluses are important in hypovolemic shock, maybe sometimes in distributive shock, but outside of that, they're far more likely to do harm, right? And there's plenty of patients you come in and you think they're in septic shock and you put the probe on their chest and their heart's barely beating, right? So phenotype your shock and look for signs of fluid intolerance before you're giving fluid. The last thing I'll say to this is shocks don't come in isolation, right? We think of our 4 types of shock: distributive, hypovolemic, obstructive, and cardiac, right? But often you have multiple types of shock with any disease state, right? Sepsis causes a cardiomyopathy. Trauma, which is a hypovolemic shock, also causes distributive shock just from the SIRSI nature of it, right? And so you're gonna find multiple forms of shock. You're often gonna find a cardiac component. You're also gonna find people that just have cardiac dysfunction at baseline and we're doing okay, but now they got sepsis. And they can have a little fluid, but their ability to tolerate fluid is far less than you would someone who had a normal functioning heart. And the most important thing is get source control, right? If you don't get source control, the patient's shock is just going to worsen and worsen and worsen, and you're going to give fluid and fluids and fluids, and it's just going to make things worse. Fluids doesn't treat almost any form of shock except for true hypovolemic shock, right? Outside of that, it's a temporizing measure, and if you're not getting source control, you're not going to fix the problem. So phenotype your shock, figure out why they're in shock, and endeavor to fix it, and give as little fluid as you have to until that shock is resolved. And then the next thing is you don't have to be perfect, right? And we know this. And one of the ways we know if this is the CLOVER trial, which is recently published. And essentially what they looked at is they took about 1,500 patients in septic shock, and they randomized them into what they called a restrictive fluid therapy group and a standard fluid therapy group. And what they found out was it really didn't matter which group you got into. And part of that makes sense because fluid is not the cure for sepsis. Vitamin C is. No, I'm just kidding. Antibiotics are. And if you're not giving them antibiotics, it doesn't really matter, right? And so if fluid's not the cure of sepsis, then you'll only harm people. But the question is, you don't harm people in the first 24 hours of fluid administration, right? If you look at the difference between these two groups, it's only about 2 liters, right? ICU drowning happens over days. You have plenty of time to realize your mistake as long as you're paying attention, right? So you don't have to be perfect. You can give some fluid up front. What I would say is make sure the patient doesn't have one of those phenotypes that do really bad with fluid administration, right? And the ones that hate fluid, that you can't even give them a little bit before they try to die on you, is the right heart failure, right? Cor pulmonale, massive PE, pulmonary hypertension. They take a joke really badly and they will try to die really quickly, right? But if they don't have those things, you can get away with testing out small amounts of fluid, right? It's over time that these realities start to take place. And so the last thing I would say to that is you don't have to be right every time you're administering fluid. You just have to recognize when you're wrong, right? You have to keep following up, keep checking on the patients, looking at your signs of fluid intolerance, right? They are going to get worse if they're there, right? So a lot of times when I'm looking, I'll look at my ultrasound and my Vexus flows and I'll see little bits of pulsatility, which are indicative that I have venous flow going the wrong way, but I'm not quite sure yet. I give a little more fluid. I'm like, oh yeah, that's pretty obvious now, right? But because you're paying attention so early, you have time to backpedal and you have time to just stop the fluid at that point, right? And I'll end with none of this is easy. In some patients, you get source control really quickly and you can give a little fluid and it doesn't matter. But the ones that are truly in shock, the ones that it's hard to get source control, you're often just between a rock and a hard place where you're in shock, your pressures are shooting up super high, you can't keep things in the intravascular space, but at the same time, you're already seeing signs of fluid overload. And again, now you're just balancing the risk-benefit of these things. It's just there's more harms to fluid and there's more harms to holding fluid, right? Pressors are your friend. I have a friend that says the best choice of fluids is norepinephrine. The harms of pressors at reasonable doses is fairly low, right? And so you can use pressors in those sick patients who you're already seeing signs of fluid harm until you get that source control. And then the last thing is when you find you're continually have to give fluids and those signs of intolerance are getting higher and higher, just double check you have source control, right? It's often the fact that you're missing something. So whether it means do a better physical exam, take the patient to the truth box and figure out if there is a source that you're not accounting for, put the ultrasound probe on, so on and so forth, right? And I'll pause there for questions.
Thanks, Dr. Spiegel. I'm going to come up to use the podium mic since we are troubleshooting our lavalier and our handheld mic. So we do have 2 or 3 minutes. Any questions for Rory on fluid tolerance? Not one. I have been monitoring the chat window. Just repeat the question.
Yeah. Yeah, that's great. So I think you could functionally say they serve almost the same things. If you look at the FACT trial, which is a fascinating trial, so the FACT trial was this multifactorial trial that basically compared a SWAN to a CVP. And turns out it doesn't matter whether you use a SWAN or a CVP, but it also looked at how to administer fluids. And so one of the groups was basically a forward flow, pushing fluid forward, trying to optimize oxygen delivery, right? And the other one was a fluid tolerant. My CVP gets to 5. So it's basically what happens with your right atrium. It's an amazing organ that essentially is built to keep your CVP as low as possible to encourage venous return, right? But there's a certain point when you take the capacitance out of that your CVPs will rise rapidly, right? And that's the indication when you've reached this point where you're going to start getting fluid congestion really quickly. And so the idea was as soon as you start hitting that point, you just stop fluid, right? It was a pretty good fluid tolerant strategy. And not surprisingly, the fluid tolerance strategy did way better than the forward flow, independent whether you had a SWAN or not. So the data would suggest the CVP is fine. The nuance of VEXUS is it's not technically your CVP. What VEXUS is looking at is your mean systemic filling pressure, which is essentially the driving pressure of your venous system compared to your CVP, right? And so you'll see there's people with pretty elevated CVPs but still have normal flows on VEXUS, so could probably get a little more fluid. Whereas if you just look at right atrial pressure alone, you'll kind of miss some of that. But overall, yeah, you're probably right. You could probably just use the CVP as long as you learn to stop early. You use renal. Yeah, you can't. It's very hard to use portal. They have low pulsatility, and then even their IVC, a lot of it is just stented open because of the scarring of the kidney or the liver, so you end up using the renal. Thanks, Dr. Awesome. Thank you, guys. Great.